Hello, everyone. It's Eric from Strong Medicine. And today I'm going to be talking about something a little lighthearted: medical slang. These are terms that doctors, nurses, and PAs frequently use in medical settings, particularly in the hospital, that you're not going to find in a medical dictionary, and which medical school is not going to explicitly teach you. Now, while disrespectful slang is a problem in medicine, for the most part, I'm going to stay away from those today. I do have a separate video from a few years ago that discusses some of that issue. The slang I'm discussing today is generally not meant to be derogatory to patients themselves, though a few terms are a little dated, and I don't personally advocate for using all of them. I wish I could share the etymology of these words, but the true origin of most medical slang remains kind of a mystery. The first well-publicized source of it was the satirical 1978 novel House of God, which described life as a resident in a busy academic hospital. But as far as I know, the author of that book only claimed to have originated the term bounce, which has since evolved into the word bounce back. So we can start right there. A bounce back, as in, we've got a new admit in the ER, but don't worry, it will be a bounce back in the morning. A bounce back is an admission who was recently discharged by another team at the same hospital. Every hospital has a different policy regarding the specifics of how this works, but the general principle is that if a patient gets readmitted for the same problem in a very short amount of time, the patient will be transferred back to the original team as soon as is practical. The reason for this is twofold. First, the original team knows the patient better and is more familiar with their medical problems, the patient's medical history, and previous treatment. Second, this provides important feedback for the original team so that they better understand what went wrong the first discharge, and so they can learn from it for next time. Black cloud versus white cloud, as in, Steve is such a black cloud, I hate being on call together. A black cloud is a clinician who seems to be consistently unlucky in the context of their job. So they get the most admissions from the ER, and they have the highest rates of code blues, that is, cardiac arrests, happening in the hospital while they're on call. A white cloud is the opposite, a clinician whose call days always seem to go smoother and are lighter than average. Notably, this phenomenon has actually been formally studied more than once, and it's been found to not be a thing. I've known my share of white and black clouds over the years, and in my experience, when a person acquires that reputation, it's because of their own disposition. How do they respond to busy days or a transient but random high frequency of adverse events? People who stress easily or who vocally express dissatisfaction, they gain the black cloud reputation, versus those who let everything roll off their back are the white clouds. It's really nothing more mysterious than that. A road test, as in, we're planning to discharge Miss Chen today. Can you go road test her? To road test a patient, or road test a hospitalized patient, that is, it means asking them to stand up, walk to the door, walk down the hallway some arbitrary distance, and return to their room as a 1-minute assessment of how physically independent they are. In essence, we're making sure that a previously independent person is feeling well enough on their feet to be safe when taking care of themselves at home. While the hospital, it does have physical and occupational therapists to do a formal assessment of this, if there had been no preceding indication of a mobility problem, an assessment may not have been ordered and is often unnecessary. But we can make mistakes with our assumptions on this, which is why the road test is important. Some written references on medical slang claim that an informal cognitive assessment is included as part of the road test, and there's various different variations on what that cognitive assessment might look like, but that's not how I've heard the term used in my hospitals. The road test typically comes shortly before their OTD, as in, my patient list is currently at 8, but 2 are OTD. This is an acronym for out the door, referring to a patient for whom all of their discharge paperwork has been completed and their discharge order is in the computer, but they are still physically in their room because they need to get changed or they need to get picked up by their ride. Diarese the list, as in, I've got 2 patients OTD and a few more discharges this afternoon, so looking forward to diuresing my list. The word diuresis normally refers to the administration of medication to increase urine production in order to lower the amount of fluid in the body. This is commonly done in decompensated heart failure or liver failure. To diurese one's own list of patients means to work hard to get patients discharged, with the net result of shortening that list and decreasing the anticipated amount of work the following day. Rock, as in, man, I can't diurese my list, too many rocks. A rock is a patient who cannot be discharged despite being seemingly medically stable. Common reasons why a patient who would be a rock or would not be able to be discharged, that is someone who needs prolonged IV antibiotics but has no medical insurance, or a patient with advanced dementia who can't be placed in a nursing home because they require continuous supervision due to wandering or dangerous behaviors. If an intern's list has multiple rocks, they might even say they are cultivating a rock garden. In my experience, from the perspective of the medical team, the term rock does not necessarily carry a negative connotation about the patient as a person. However, because patients and families may very understandably interpret it negatively, it's best to avoid it. Turf versus dump versus block, as in, why does ortho always dump every demented old lady on medicine? Or, I can't believe we just turfed that potential rock to gen surge. Turfing a patient means one service is redirecting them to a different service without necessarily implying anything negative about the patient themselves. Dumping a patient is when the patient being turfed is seen as someone who is likely to be unpleasant, difficult to care for, or someone who's going to become a rock, quote unquote. And blocking a patient is when one service refuses to be turfed to or dumped on by another. Now, I don't recommend framing such situations as a block, even when that decision to decline a patient was the correct one. I tell my residents, we don't block patients on medicine. We redirect them to more appropriate avenues of care. Similar to the concepts of turfing and blocking are sieve versus wall, as in, I dread being on call with Dave. He's such a sieve. Why can't he be a wall like Sarah? A sieve is a resident who accepts every admission from the ER without giving any pushback as to whether the patient needs admission or would be better admitted to a different service. Whereas a wall is the opposite. Although overworked interns universally prefer walls in their residence, the best residents are actually somewhere in between. If it's an appropriate admission to their service, they should accept it without issue. And if it's not an appropriate admission, they should respectfully work with the ER to identify a better plan for the patient. Pop drop, as in the ER just called with a new pop drop. A pop drop is another term in the video that I advise against using. It's not intended to be derogatory to the patient, but is uncharitable towards the patient's family. It refers to an admission from the ER in which an adult child who had previously been the caregiver for their elderly father, and who has determined they can no longer do so because of the patient's medical problems, the fact that they've progressed to requiring more care, or because the child's own circumstances have changed. And the implication is that the child has pulled up to the ER, walked their dad to the triage nurse, checked him in, and then just drove off, which in reality is not how it typically plays out, though I have seen that a few times. In reality, most children caregivers of elderly patients who find themselves in this situation, who are bringing their father or their mother to the ER for lack of ability to care for them, they experience a lot of guilt, and they often have been unsuccessfully trying to find an alternative care solution as an outpatient for weeks. However, at the same time, the dad doesn't actually have any acute condition that would normally warrant hospitalization, leading to frustration for the medical team as they feel like these admissions are using them as social workers, which they sort of are. Vitamin V and or Z, as in Mr. Jones is spiking a fever with his new O2 requirement, so I started some vitamin Z. Vitamin V is the antibiotic vancomycin, and Z is for Zosyn, more formally known as piperacillin tazobactam. Referring to them as vitamins is a playful way to acknowledge that they are two of the most commonly prescribed medications in the hospital. Gravity rounds, as in, do you have a preferred order to see the patients in, or are gravity rounds okay? This term is used in the context of walking around the hospital as a team to see your shared patients. It refers to taking the elevator to the highest floor in which the team has a patient, and then using the stairs to gradually make your way down one flight at a time. I found the term gravity rounds was much more common on the East Coast, where city hospitals, they could be 15 or 20 or even higher in terms of how many stories tall they are. And elevators were incredibly slow, so you'd want to minimize how often you relied on them. In particular, I'm thinking of Tisch Hospital in Manhattan was particularly infamous for this. The term and concept in general, they aren't very relevant in hospitals of only a few stories. Code brown, as in, good Lord, did you smell that code brown by the nurse's station? As is commonly known, a code blue, as I mentioned before, is a cardiac arrest. A code brown is a massive, very pungent, and usually incontinent liquid bowel movement, the smell of which takes over the entire ward. Supratentorial, as in, we've ruled out cardiopulmonary causes of Mr. Williams' chest pain. I think it's supratentorial. In the anatomy of the brain, there is a structure called the cerebellar tentorium, which is an extension of the dura mater that separates the inferiorly located cerebellum from the superiorly located cerebrum. Everything above the tentorium is referred to as supratentorial. The cerebrum is the source of memory and reasoning and most notably emotion. So if a symptom is said to be supratentorial, the clinician is suggesting it is psychologic or psychiatric. For example, chest pain due to a panic attack. It is a euphemism for what laypersons understand as a so-called psychosomatic problem. When a clinician uses the term supratentorial, they are not usually meaning to imply the symptom is not real or doesn't need to be treated, but sometimes that the implication is intended, which is why it's another term that's best avoided. To pimp, as in gyne rounds, it really sucked today. I got pimped by the chief for like 30 minutes straight. To pimp is a common but unfortunate term that refers to a style of clinical teaching in which the resident or senior physician repeatedly asks the learners challenging questions that usually test their ability to remember minutiae of questionable relevance to patient care. Medical schools and educators, they condemn both the term and the practice, but both the term and the practice still persist on the words. However, it is necessary to distinguish classical and inappropriate pimping from a physician just asking students questions on rounds in front of their peers. If done supportively, that can be an engaging and effective way to teach, versus pimping, which is by definition something that generates a toxic atmosphere, sometimes with the intent of demonstrating a student's ignorance, and which usually results in embarrassment and dread. All right, what we got next? Slow code, as in, I think Ms. Romanoff might code tonight. If she does, I suggest making it a slow code. A slow code is a controversial practice in which the medical team deliberately responds slowly or incompletely to a patient experiencing a cardiac arrest because efforts are perceived as futile. It is used in situations in which the patient has a poor quality of life at baseline, has an advanced irreversible condition such as dementia, and either the patient or more commonly the patient's family still requests all aggressive attempts be made to extend life as long as possible. From my perspective, every slow code represents a communication failure between the medical team and the patient's family. While I understand the reason behind slow codes, the general consensus is that they are unethical because at the very least they involve deceiving the family. And I definitely do not recommend deliberately labeling any code as a slow code. Having said that, there is a lot of room for interpretation during a cardiac arrest as to futility. And most people, including members of the public, for example, they would consider it justifiable to continue resuscitation efforts for longer and more aggressively in a previously healthy child with a treatable infection as compared to a 90-year-old with end-stage dementia. So in short, there is some gray in what can be considered a slow code, or what is considered to be a ethical approach to futility of care in the event of a cardiac arrest. But just don't use that term on the words in the context of a specific patient. Sniff pronounced, or SNF pronounced sniff, as in we can't discharge Mr. Goldstein to home because he failed his road test. He probably needs sniff. SNF is an acronym standing for Skilled Nursing Facility, which laypersons would understand as a nursing home or rehab center of some kind. As an interesting language quirk, it's often used without the article A in front of it. It's also occasionally used as a verb, as in, we need to sniff Goldstein, meaning send Mr. Goldstein to a sniff. Poor protoplasm, as in, we're never going to be able to sniff Martinez. We can't get past her poor protoplasm. As you may remember from high school biology, protoplasm is the somewhat archaic name given to like this jelly-like substance inside living cells, composed of like water and electrolytes and proteins and of course the organelles as well. And in essence, protoplasm is the stuff that life is made of. When a patient is described as having poor protoplasm, it means that some combination of chronic illness, malnutrition, immune system dysregulation, and advanced age makes their body intrinsically resistant to attempts to heal their illness. Zebra, as in stop testing for zebras, you're wasting healthcare dollars. A zebra is a rare diagnosis. It originates from the saying, when you think of hoofbeats behind, when you hear hoofbeats behind you, don't expect to see a zebra, or alternatively, when you hear hoofbeats, look for horses, not zebras. Variations of this have been attributed to Theodore Woodward, who was a professor from the University of Maryland, though it apparently wasn't seen in print for like 20 years after he supposedly said it, which, calls into question its true origin. Regardless, it's intended to be a statement countering something called the base rate fallacy, in which the overall prevalence of a rare disease in the population is ignored when determining the probability that a patient's illness is due to that disease. A common disease is a horse, a rare disease is a zebra, though in practice, only the latter is used in common conversation on the wards. Zebra is a near synonym for fascinoma, which is a diagnosis that is particularly interesting to physicians because it's either a rare disease or because it's an unusual manifestation of a common disease. Fascinomas, they should not be confused with incidentalomas. These are findings usually radiographic that are incidentally discovered while looking for something else. For example, if a patient presents with acute chest pain and gets a CT scan of the chest to evaluate for a pulmonary embolism, and the CT, instead of a pulmonary embolism or a blood clot, it instead shows a small pulmonary nodule that is unlikely to be causing any symptoms whatsoever. And you might think that incidentally finding abnormalities would be a good thing because you've potentially identified a serious disease at an early stage when it's more treatable, and sometimes that is the case. However, incidentalomas can also be a huge problem. I have a whole video about the expensive and unexpected consequences of my own incidentaloma uncovered by a brain MRI, and I'll have a link to that video in this video's description. And last, I'm going to end today with a fun one that I actually enjoy, and that's winning the game. As in, if case management can find Mr. Goldstein a sniff this afternoon, I might actually win the game. Winning the game means an intern or resident has discharged every patient on their list before needing to admit someone new, which, if they aren't on call the following day, can result in an extra day off. Now, winning the game on a typical inpatient medicine service in 2024 these days, it's profoundly rare. As an attending who typically works with 2 interns, each of whom has their own patient list, in the last 20 years, I've won the game, meaning both of my interns won the game on the same day, precisely one time. But that was a truly glorious day. Anyway, that's all I got for today. I hope you enjoyed that quick rundown of some common slang among healthcare professionals. While some of them are amusing, as I talked about along the way, I don't recommend all of them. And, feel free to leave your own favorite slang term in the comments below.